Hi, so in my talk, I'll focus on the clinical aspects of West Nile, and I'll tell you about a retrospective study that we did here, West Nile virus outbreak in 2024 compared to previous seasons. And this is the long list of people who were involved, and I will thank them again at the end. So for those who are not clinicians, a very brief overview on the clinical presentation of West Nile fever. So the virus incubates for a short time of 2 to 6 days, and then only 1 in 5 people would be sick. And usually it's an acute, non-specific influenza-like illness that lasts 3 to 6 days. And the physical examination rash we may see in about half of patients, and much less commonly we see conjunctivitis or lymphadenopathy, and even less likely to see hepato or splenomegaly, so a non-specific illness at all. However, less than 1% of those individuals who were infected with the virus will develop a severe disease, a CNS disease, neuroinvasive disease, and this usually appears after a few days of fever or a biphasic course. Like there's a fever, patient improves, and then boom, the neurological symptoms. And the main risk factor for the neurological illness is older age. This is consistent in studies. Older age is associated with a severe CNS disease. The presentation of the neuroinvasive disease is mainly encephalitis, and this is followed by meningitis, and less commonly a disease that is similar to poliomyelitis. And movement disorders are typical for West Nile, and we see those patients with tremor, and we know that this is the West Nile and not another disease, probably. Previous outbreaks in Israel, so the largest outbreak described this far was in 2000. We had there over 400 cases, and the mortality was about 10% overall, inpatients and outpatients. You'll see the mortality in this season later, and you will have the impression of how severe it is. 2 other outbreaks were in 2015 and 2018 with about 150 cases each of these outbreaks. And all the outbreaks, including this one this year, had several common characteristics. First of all, they started early during the season. You'll see that this year it started on May, which is early. And the geographic spread was mainly in central Israel. We tried to collaborate with friends in Rambam, for example, for the trial Gili presented, and they had no cases. And also, Yaniv will speak about the viral lineage, which is viral lineage 1 in all these outbreaks, including this year. So we're coming to this year's outbreak, and the outbreak started, as I said, during May. Okay, early in the season, and overall until the end of the season, end of November, we had almost 1,000 cases in Israel with a mortality of 8%, and this is overall mortality hospitalized, but also non-hospitalized patients. So considering the unusual size of this outbreak and what we saw here, and the research coordinators were shocked by these older adults that were 2 days ago in a demonstration in Kaplan, and then they came here completely unconscious. So it was kind of something strange for us, even for us, the physician, to see. And we thought, what can we do? And we thought to circulate this data as soon as possible. And what we planned is a retrospective study to describe those cases in this season, try to compare to previous seasons, and to find predictors of poor outcome of these patients. So practically, we conducted a retrospective study. We included all consecutive adult patients that were hospitalized in Sheba and tested positive for West Nile, again, between May, when the outbreak started, until end of July. This is when we decided that we're going to collect very rapidly the cases. And we compared these cases to previous seasons, to 2018 until 2023. We chose 2 co-primary outcomes that we thought are most significant for patients. So one is, of course, mortality at 30 days. And the other one, which we called poor outcome, combined things, the bad things that we think could happen to a patient hospitalized here, which is one, mortality. The second very bad thing is to be hospitalized a year for over a month, as you well know. And another bad thing is for patients who come from home to be discharged not back to their homes, but to any institution, either rehabilitation or a long-term term care facility. Okay, so came from home and discharged somewhere else. We define West Nile disease as any symptomatic illness with a laboratory diagnosis of West Nile that included either a positive IgM or PCR in either blood or CSF. Okay, simple, that was the diagnosis. And what we did was comparing this season to previous season, 6 years before 2024. And also we took the entire cohort, all the patients since 2018 until 2024, and we tried to find predictors for these two co-primary outcomes that we defined. So these are the results. Overall, we had 134 patients. Pay attention that 103 were hospitalized this year, and only 31 patients were hospitalized with West Nile during the 6 previous seasons. Okay, so this was a large outbreak. Basically, there were no statistically significant differences between the patients in these two periods of time. However, you can see in red that there were some differences. The cohort of 2024 tended to be older patients, less independent in their functional capacity, more likely to have comorbidities, and mainly more likely to have severe immunocompromise. And the severe immunocompromise we defined as either one of this, of these characteristics. However, in practice, what we found, this is the list of the immunocompromised, severe immunocompromised patients, and what we found is that all of them had B-cell depletion, either anti-CD20 therapy for any disease, or hematological malignancies with B-cell depletion, CLL, multiple myeloma, or any kind of lymphoma. So these were actually the patients that we defined as severe immunocompromised. As you can see in the bottom line, mortality in the 2024 season was 15%, considerable mortality. If you think about gram-negative bacteremia in hospitalized patients, it's the same mortality, similar. So high mortality of 15%, and in previous seasons, it was only 7%. Overall, a quarter of patients that came here from home were not discharged back to home. Okay, so it's a serious disease. Breaking to several groups, we found that patients that are over the age of 80 had an 18% mortality, so poor outcome for older adults. Patients with non-invasive disease, again, poor outcome, 15% mortality. And I've mentioned the severely immunocompromised B-cell depleted patients. These patients had 27% mortality. Okay, it's not a lot of patients, it's 15 patients, but 4 of them died. In the multivariable analysis we did for predictors of the poor outcome, either mortality or what we defined poor outcome, we found only age as a significant predictor with an odds ratio of a little over 1 for both mortality and the poor outcome composite. Regarding the immunosuppression, an odds ratio of over 3 for mortality was found for severe immunosuppression. This was again not statistically significant, but the sample size is small here and the confidence intervals are broad. The odds ratio are quite impressive. And when we introduced the time period into this multivariable analysis, this was not statistically significant. So if we summarize what we found in our cohort, we found a mortality of 15% in the current outbreak of among hospitalized patients. And this mortality was 7% in previous years, in the previous 6 seasons. And this is probably explained because the differences in the population of patients, the 2024 patients were older, they were less likely to be independent in their functional capacity, they were more likely to have comorbidities and substantial immunosuppression. We thought that maybe there was a higher index of suspicion. This year to test for West Nile, we really tested everyone. And in previous seasons, we might have missed a patient with lymphoma who comes with fever. There are a million other reasons, and maybe we didn't test for West Nile. So this may explain some of the differences. Regarding the virus itself, Yaniv will speak about that, but it was probably not, there were no differences between the seasons, and it's the same virus, so this cannot explain the differences. If we compare to mortality in the previous literature, so it's kind of similar to what we found in USA in a cohort of over 1,000 patients in 2022. They describe 11% mortality among hospitalized patients. In Europe in 2023, there are less cases in Europe than in the United States. So here there were overall 700 cases and mortality was 9%. And in previous series of patients with non-invasive disease, the mortality ranges between 9 and 18%. So our mortality is according to previous literature. Regarding the predictors, again, we found that older age was the only statistically significant predictor for poor outcomes. We had a trend with higher Charlson score for poorer outcomes. And as I've mentioned, B-cell depletion was also associated with higher odds ratio for mortality. And this consists with previous reports, predictors for the poor outcomes in the literature. The most consistent one is older age. And other that were reported inconsistently is one, male sex, that we did not find in our cohort as a risk factors, comorbidities that we found some signal. And in previous series, there was a variable that is called like non-specifically cancer or immunocompromised, which I think we specified more deeply. And there is we found only one recent series of 21 patients with lymphoproliferative diseases. And among them, 15 had West Nile non-invasive disease. And of these 15, 6 died and 9 had neurological sequelae. So they had poor outcomes, as we found in our B-cell depleted patients. And this reminded us of what we saw in COVID. B-cell depletion was associated with worse outcomes and sometimes persistent illness of COVID. Limitations are, of course, a small sample size from a single center. As Gili presented, concomitantly, we ran here the randomized controlled trial, and some patients did receive a trial investigational therapy, so this may influence our results. But overall, we can conclude that first, West Nile virus has a considerable mortality that we saw here in 2024 of 15% overall. We also saw in all the seasons prolonged hospitalization in over 10% of patients, and 25% of them were not discharged home, meaning that they had some functional and or cognitive decline during the hospitalization for West Nile. Age is definitely a risk factor for mortality, and probably B-cell depletion is also a risk factor that should be further investigated. And I would like to thank all the departments that contributed to this data collection, the internal medicine departments that treated the patients and collected the data, the central virology laboratory, the neurology department, and all our units of infectious diseases and infection control. Thank you.
So I'm not sure if you looked at that at all or not, but I wonder if you found any link or any connection between the viral load and the mortality.
We did not look at this yet, but the viral load, I think there was very small variability. It was very similar in most of the patients.
So it's probably not a risk factor.
Another problem with this is that each patient came in another time point in the disease. Some patients presented after 2 days of illness and some after 3 weeks. So it's not the same time point of the illness. So it's a bit tricky. But we have the data.